Hello, everyone. Welcome to another Residency VMR. Today, we are very excited because we have very special guests. We have the chief residents from Wake Forest University with us. And as the Residency VMR format, you guys already know, we'll have like the case presentation, and right after it, we're gonna have like questions that can be answered by the chief residents, and you can get to know more about this residency program. So I would like to pass the mic to Lily, which is one of the chief residents at Wake Forest. Could you please introduce yourself and tell us something that you like to do outside of medicine and also your favorite ice cream flavor?
Good morning, everyone. My name's Lily Pitts. I'm one of the chief residents. I'm so excited to be here with you this morning. We're going to have a great time. So my favorite ice cream flavor is probably chocolate chip cookie dough. Um, a classic. And then as far as things I like to do outside of medicine, I really enjoy being outside and going hiking. So I get to do a lot of that in North Carolina when at Wake Forest. So that's me.
Awesome. Nicole would like to say hello.
Sure. Good morning, everybody. I'm Nicole Sills. I'm one of the co-chiefs as well. My favorite ice cream flavor is piece of cake. Very different than birthday cake. Piece of cake is so good. And what I like to do outside of medicine is, as Lily can attest, is probably yoga and this hot Pilates, mat Pilates. I can't do the reformer, but that's been fun.
I totally resonate with that. I love Pilates, and I'm trying to find a new place of Pilates where I live, so I would like to get some recommendations. And
Yes.
last but not least, Zach would like to say hello.
How's it going, everybody? Thank you so much for having us. Definitely an honor to be here. My name's Zach. I'm also one of the chief residents here. My favorite ice cream flavor by far is vanilla with Reese's cups in it. Incredible. There's one of my favorite spots in town that does it better than anybody else. So huge fan of that. And similar to Nicole and Lily, I like exercising a lot too. So I'm definitely in the gym or riding my bike. Those are the two things that I like to do the most.
Mariana, you're muted.
Oh, thank you. I was gonna say that with so many good ice cream flavors, I'll have to try a new one because my favorite one, I've already told you guys that is dulce de leche is the only one that I actually have, but I'll have to try new ones. And I would like to introduce Jazz, which is our ice cream fanatic. Jazz would like to say hello and introduce our amazing Sipsovers members that is going to discuss with you today.
Hi, everyone. My name is Jazz. I'm a academic and community hospitalist at Rochester, New York. And my favorite ice cream flavor is pistachio gelato. But if it's ice cream truly, there's one near our city that's called Cookie Monster, which has Oreo and regular cookies in there, which is really good. And I have the absolute pleasure of co-discussing with both Yaz and Deborah. So I'll turn it over to Deborah first to introduce herself.
Hey everyone, we are super happy to be here today with Wake Forest. Thank you for accepting our invitation. And yeah, I am one of the leaders of our virtual morning report. I'm from Brazil and trying to get here in the residency. And my favorite ice cream, I think, could be cookies and cream. I really like that one. And yeah, excited to try all the flavors you guys had. Yes, hi.
Hello, everyone. I am very happy to be here discussing with you all. And yeah, I am, yes, from Mexico, based in San Antonio. Approximately, I will be on Baltimore now. I'm very, very happy. So my favorite ice cream flavor has always been pistachio. So yes, I'm very excited for this.
All right, so Lyra, if you could please share your screen and we can get started with the case. Whenever you feel ready.
All right. Yes, so I'll get started. So our chief complaint is a 53-year-old man with minimal healthcare exposure presented as a transfer from an outside hospital for cough, dyspnea, and fevers for 2 weeks. He previously presented to an urgent care clinic for the same symptoms, and at urgent care, he was noted to be hypoxic and as such presented to the outside hospital and ultimately was transferred to our hospital. He noted a 2-week history, as I said, of dyspnea, productive cough of brown sputum, and intermittent fevers. These symptoms have been progressively worsening upon presentation. So for his ROS, he noted the dyspnea, fevers, productive cough, poor PO intake, and unintentional weight loss over the last 2 months of an unknown amount of weight, he said. Pertinent past medical history includes tobacco use disorder and no other known medical history, no known surgical history, and did not take any medications at home, including no over-the-counter medications. Family history was notable for a brother who recently passed away from lung cancer and a mom with COPD and colon cancer. Social history includes he lives in a house with a wood stove and no central air conditioning. He has a 20-pack year smoking history, no alcohol use history, no illicit drug use, sexually active with one partner who is his long-term girlfriend of the past 33 years. He lives at home with 2 beagles as his dogs. No recent travel, no sick contacts. He did used to work in landscaping for about 5 years, but no longer currently working. He's never traveled outside the United States, let alone North Carolina, where he lives. He's never been in the military, never gone to jail or prison, and no tattoos or IV drug use. And as far as allergies, he noted codeine, and it was jittery with such.
Whoa.
And I can repeat anything if you need me to.
Thank you. Thank you so much. What a great start. So going for the chief complaint, dyspnea is definitely one of my favorite chief complaint, and we always like here try to think about if could be in the heart, if could be in the lung, or if could be like something else. In the heart, definitely think about if this patient had heart failure or an acute coronary syndrome, and going for the lungs, going if could be some asthma, COPD, and like could be like other things. I think acidosis, anemia. But here with all this presentation, I think we can go more for the lung. I think that's where we can start thinking about it with this cough, this dyspnea, and it's a patient that smokes. So definitely like with this unintentional weight loss, make me think about like if could be like some malignancy that he could be presenting, as the smoking can be a huge risk. And like this coffee dyspnea make me think like maybe it's a COPD exacerbation if he's having like any infection that it's bringing him. But, and yeah, I would definitely be worried. Like I think the hypoxemia make me think like, okay, this patient, it's really sick and really need like a big investigation to see what's going on. Yes, what do you think?
I really like the way that you started looking at the dyspnea. I am very interested to see that this is a 2 weeks onset. This patient has been having these issues for 2 weeks. And one of the buzzwords that came like up to me was the brown sputum. Not only he has dyspnea, you did very well in mentioning something malignant, which can evolve in a more subacute setting. I'm thinking, well, what can this symptoms show? And when we have rusty or brown color sputum, I think about something causing vascular congestion, which causes this red hepatization of the lung. I'm sorry, I'm bringing step 1 things right now. That cause this like bloody, rusty tinge of the sputum, and that is one of the main like the main ID causing is pneumococcal pneumonia. It can also be tuberculosis, but aside from ID, before I anchor, can also be malignancy. It can be an inflammatory process. And here another thing that they gave us was this beautiful social history. This patient has a wood stove, and something that I learned from being a rural doctor back in Yucatan was that using wood stoves predisposes patients to COPD or to malignancy later in life. Also, he worked in landscaping and he lives in North Carolina, which has lots of endemic diseases. But before I anchor and start rambling about that, because I love ID, Jess, what do you think?
I was betting that you was gonna say something ID related, and I think that's appropriate. I don't have too much to add. I think I'm not gonna make any formal impressions because it's still too early, and I agree with you that the social history definitely piques my interest, but this could be something common, like a patient that, especially as a patient has been disconnected from the healthcare, could he have had lung cancer and now has post-obstructive pneumonia? And if we get a CT scan, we're going to see a large mass with concerning signs for pneumonia, and then that can explain the intermittent fevers and the productive cough. But if we take a step back and say, okay, if that's not it, if this is all pneumonia or infectious related, I would say that given his risk factors, I think fungal and atypical infections could also be fitting this subacute timeline. But right now, I think it's noted what his prior social history exposures are with the wood oven and the former landscaper. But I think the main thing I'm focusing on right now is this weight loss for 2 months, and his now seems like this was subacute chronic process with an acute decline. And what's causing that acute decline? And I think that's where the next element will probably shed some more light on it. So that's the only thing I would summarize, but you both touched upon a great list of differentials there.
All right, were you ready for the second aliquot?
All right, perfect. Going into the vital signs, his temperature was 99.3 degrees Fahrenheit. His blood pressure was 116/71. He was tachycardic with a heart rate of 121, and also hypoxic, satting 99% on 4 liters of oxygen via nasal cannula. Interestingly, his weight was 48 kilograms and his BMI was 14.8. So on exam, given that weight, things that stood out to us were that the patient was ill appearing and cachectic on initial evaluation. Overall, his HEENT exam was largely unremarkable, normocephalic with extraocular movements intact. Cardiac exam, he was tachycardic as noted in the vital signs, but otherwise normal rhythm, normal S1, S2 with no murmurs, rubs, or gallops. On lung exam, he had limited air movement and diffuse rhonchi throughout, and was noted to be satting on 4 liters, as mentioned previously, and an active, productive coughing during inspiration. On abdominal exam, soft, non-tender, bowel sounds were all present. On extremities, no edema to speak of, and also had strong peripheral pulses that were all intact. And then on his neuro exam, there were no focal deficits. Patient was alert and oriented ×4. And then I'm happy to go into the labs, but if you guys wanted to talk about the exam for a second, hold off for now.
I think we can comment on this if you guys want to start. Thanks, Zach.
Yes, do you want to start?
Oh, of course. Yeah. Well, the first thing that stood up a lot to me was the BMI 14.8, which makes me think that this not only has been going on for 2 weeks. I would definitely ask the patient if they had noticed this weight loss for even longer, because this makes me think that there are a lot of cytokines, cachectins, making him like this causing this muscle consumption. If I'm not wrong, my calculations is the temperature in Fahrenheit is 37.2 Celsius. So he's not febrile. He's tachycardic though, so I would definitely look at the CBC afterwards to see if there is anemia, which I am thinking he would. I would be really puzzled if he didn't have any anemia. There's limited air movement and diffuse rhonchi. So I'm thinking, could there be any consolidation process, interstitial issues? Like my next step would be asking for an chest X-ray, and from there more imaging. But yeah, that's the main thing I looked at. What do you think, Dad?
Yeah, same as you. I got really impressed, like with the BMI of the patient. Seems like he's really in a chronic well and make me worry. Like I was definitely thinking if he has any anemia, how is his eating? Like maybe if he could have like some electrolytes problem, potassium, phosphate. Definitely, I would like to check that. Vitamin B1 too, and desaturation. Like we need to continue checking to see if he will not be enough, to see if we'll have to change the oxygen for the patient. And so, yeah, now I think we see that there's an inflammation in the patient and could be, I'm going more like it could be an infection or could be a malignancy. That's, I think, the two buckets I will definitely go look for and an imaging of the chest for sure. What do you think, Jess?
Yeah, I feel like you probably got a chest X-ray, but I think even after basic labs, he's probably going to get the truth. Or Yaz, if you guys were to predict his labs, what would you guys say?
If I have to predict his labs, um,
Yeah.
I think I would predict an anemia.
Okay.
That's a good question. I'm thinking if the white BC would be elevated from an infection or, oh, I don't know, or if he's immunosuppressed and would be low.
Yeah. No, I agree with you. And then what about Yaz? What anything that you wanted to add?
No, definitely. I will be very puzzled again if this patient did not have anemia and white blood cells. For some reason, I'm not thinking this could be an infection. For the first time in many VMRs, I would say that maybe this is malignancy. But again, I'm not trying to find a diagnosis beforehand. We're trying to do this like clinical reasoning exercise. Maybe a reactive thrombocytosis, maybe. But again, there is this like dichotomy of what if with this high inflammation picture, I'm wondering if the bone marrow is like actually working the way it should be. So yeah, I'm looking forward for the labs.
Yeah, no, I the reason I asked is because I'm struggling with that myself. So I think I don't have too much to add in terms of what you guys think is going on. I think there's still with the subacute chronic, I think it could be like a fungal pneumonia. He definitely has risk factors for soil fungus, especially with the landscaping history. And then the other thing I said in the previous aliquot, this still could be post-obstructive pneumonia from a malignancy in his lung, right? And he has risk factors for that. And then the thing I'm struggling with the labs because I agree with what you said in the chat. Yeah, is this BMI? Has he always been a slender individual? I would say in this case of this case of this, morning report and the fact that he told us that for the last 2 months he's been losing weight, that BMI is alarmingly low. And I would imagine that he was probably closer to the 20s before. And if I were to guess that this is probably a subacute to chronic inflammatory disease, so with an acute exacerbation or acute progression. So what I would say is I think probably there would be a mild to moderate leukocytosis. It may be even suppressed. If it's suppressed, I'll be more concerned for like HIV. But I think regardless, sending that off with the basic labs is not unreasonable. But I agree with you, Deborah. I would be surprised if he doesn't have at least a normocytic pneumonia to a certain degree. Iron deficiency in the setting of malignancy is possible. I don't see much of a platelet elevation or decline unless we're thinking of tick-borne. So that would be very interesting to see what the platelets are. If they're normal or thrombocytosis, I think tick-borne goes much less likely. And I would be really carefully looking at the sodium. Does he have any hyponatremia? And if he does, that's when you get concerned for lung pathology like SIDH for a lung malignancy. And then if the renal function takes a big hit, then we have to see, are we in this pulmonary renal syndrome bucket? But that's where I'm sitting at. I'm very excited to see what the next aliquot shows.
All right, awesome. Well, I'll go ahead with the basic labs and imaging studies that we got right when he presented. So starting out with hematologic labs, his white blood cell count was 22.8. Hemoglobin was 12.5 with an MCV of 94.6. His platelet count was 494. The team also collected chemistries. Sodium was 135. Potassium was 3.8. Chloride was 102. Bicarb was 25. Normal anion gap. Glucose was 67. BUN was 13. Creatinine was 0.47 with a maintained GFR. Calcium was 8.4. His total protein was 5.6 with an albumin of 2.5. Looking at his liver labs, his T-Billy was 0.4. Alk phos was slightly elevated at 158. ALT was 33. AST was 56. And then his magnesium was 1.5 and his phosphorus was 2.2. The team also, given this, how sick he appeared and the cachectic status that he had, got a lactic acid to ensure there was no kind of underlying lack of perfusion. That was 1.4. They got an initial EKG to evaluate his tachycardia that showed sinus tachycardia with a heart rate of 132 beats a minute without any other pathology noted. His initial chest x-ray showed hyperinflation consistent with obstructive lung pathology, along with dense areas of consolidation throughout both lungs and bilateral cavitary changes. And I also forgot to mention they got a flu and COVID test that was negative and an HIV test that was negative.
Okay. Actually, we see that the patient has an elevated WBC that probably make us think that he could have an infection and make me think like he's not so immunosuppressed. And the HIV is negative and hemoglobin is low. Like we said, we were predicting probably like some anemia, probably like anemia of chronic disease, or can definitely like well, there like some iron studies to check. And this consolidation in cavitary lesions definitely like ring a bell on me about some infection. It could be like a TB, or could be like some endemic mycosis. Even like I don't know if like TB really happens a lot in North Carolina, and he didn't travel anywhere outside the US, but definitely like some endemic mycosis make me think about it. What do you think? Yes.
Well, it's very interesting. Like this patient does have a low hemoglobin, a quite high white blood cell count. The only thing that I see quite high, and please correct me if I'm wrong, the alk phos, I think that's normal still. So again, we have hyperinflation, bilateral dense areas of consolidation, like cavitary lesions in a patient with cough, dyspnea, rusty sputum, and fevers. One thing I would definitely like to test is for tuberculosis with AFPs, sputum AFP, like cultures. I would also think about hypersensitivity pneumonitis, because again, this patient has been a smoker for 20 years, and also the exposure to wood stove. Maybe a high resolution CT scan to look for this findings of central lobular nodules and this like mosaic pattern. Another thing that I would definitely look for would be, again, try to find if this is not a malignancy. We're not looking at malignancy, lung cancer, as Dr. Jazz mentioned, post-obstructive pneumonia, and maybe CT chest with contrast, or a bronchoscopy afterwards if we find something there. But yeah, those are like my three main differential diagnoses after seeing that this CT chest, chest X-ray. What do you think, attending Dr. Jess or Deb?
Oh, yes, I was gonna compliment what you said about hypersensitivity. That's a good thought. I was thinking too, it could be like an interstitial lung disease. Sometimes I'm like smoking, it's obstructive, but can be restricted too. So you bring that back on me, and definitely could be like something, a hypersensitivity pneumonitis. What do you think, Jess?
Yeah, no, not again. You guys don't even need me here. I think I think the crux of the last aliquot was the X-ray finding, because if there was notable findings of potential cavitary lesions on the X-ray, I'm curious to see what the CT would show. You know, it would probably show like a pretty significant cavitary lesion that we'll get better visualization for. But I think staying true to base rate, I think, you know, the first thing that I think about is, could this be a bacterial necrotizing pneumonia like Klebsiella, Staph aureus, and some of the other anaerobes are very notorious for causing cavitary lesions, but the timeline doesn't fit. Why would it be going on for 2 months and he did not come in completely septic, right? The other thing is like malignancy, squamous cell carcinoma is actually notorious to present in a cavitate or a cavitary type of pattern. And then like a GPA, Wegener's, formerly known as Wegener's, so granulomatosis with polyangiitis is also something that has cavitary nodules. So I would be very curious to see that. Now, you don't always have to have renal involvement, but I would love to check a UA on this gentleman to see if there might be any proteinuria or hematuria. I think you guys mentioned already with the, you know, the TB and fungal and the atypical category. I think though with his landscaping history, the biggest risk factors he has is soil-based endemic mycosis, so histo and blasto, they both can cavitate. I think that definitely has to be on the list. But staying true to a base rate, could this all be squamous cell carcinoma with a secondary pneumonia now? So I think that's where I'm sitting at, but I'll be very curious to see. I'm assuming the CT would be the next aliquot, but let's see what the next aliquot shows.
All right, are you guys ready for the CT? We'll pull it up and have y'all take a look, and maybe discuss a little bit your thoughts on our initial images, and then I can walk through kind of what our radiologist thought. Does that sound okay?
I see a very bad log.
You see an oh no sign.
Deborah, do you want to take a first crack at it?
Okay, so I'm not an expert, but we can see like some fibrosis, a lot of cysts. I think that could be like some honeycombing. Maybe some grand glass opacity too. Yeah, that's what I see.
Yeah, lots of stuff going there. Anybody else have any comments before I jump into the official read?
Yeah, I can try. Although I'm not very good at CT, like reading, I am ready to have the radiologist like, bonk. So I think that this look like diffuse nodular opacities and like this like patchy consolidations in both lungs. I'm seeing like it could be like central, but like central peripheral, like there is diffuse. So yeah, I'm thinking that this could be a more systemic disease. Again, I'm not putting my finger out of tuberculosis and non-mycobacterial, non-tuberculosis mycobacteria. So yeah, like I would definitely love to know how bad or good I did.
I just want to clarify, Lillian, or Lily, sorry, was that was that IB contrast?
Yes, there we got a CTA.
Okay, so because I see like there's a lot of part of the lung that was filled with contrast, which was interesting to know, but I don't have too much to add to what Yaz and Deborah already said. It. This is what we said earlier, like this, if the X-ray showed a possible cavitary lesion, the CT was probably going to be very alarming. So what did the radiologist say?
So no evidence of a pulmonary embolism, but dense left upper lobe consolidation with underlying cavitation, and then the bilateral areas of cavitating nodular consolidation. And then there's also that large, thick-walled cavity within the right upper lobe with superimposed gas and fluid levels. And then also bilateral hilar adenopathy, which was, presumed reactive, and then some other things, a little bit of aortic atherosclerosis, and then emphysema, so kind of some of that ground glass opacities we were talking about there, but quite a lot to take in on that CT. Do we have any thoughts about potentially diagnoses based on this, or would we like to move on to the other labs? I think we could talk here.
Like I can take a shot at this. For starters, upper lobe is like the preferred area for aspergillus and for TB. So I'm still thinking of getting a sputum cultures, but in the meantime, we can get like smears and thinking of maybe bronchoscopy with the BAL to assess if there is any lymphocytosis to see what's in there. Because I was also thinking, what if this patient already had, like, how maybe this is biased from CP solvers, VMR, but sometimes patients come here with like a 2-hit issue, like he already had this inflammatory issues by being exposed to smoke, and then he was predisposed to have these types of infections. So I'm thinking maybe next step, I would definitely ask for this cultures of the sputum and the bronchoscopy, but maybe I'm being too invasive right now. What do you think, Deb?
No, I'm right there with you. Definitely like some blood cultures. Jess gave it a really good thought. Maybe some urinalysis. Definitely like check on that. Yeah, like I'm excited to see what's gonna come next.
Yeah, I agree with both of you with this. So the CT is pretty alarming, and I think one thing that I wanted to zoom in on is the cavitary lesion with gas and fluid. And you even saw it was lighting up on the contrast. I think that's interesting because that makes me think about what's the fluid? Is it blood or is it pus? And if it's pus, I don't know. I haven't seen many TB cases, and I've seen some endemic mycoses. They don't typically have pus, and I wonder if was this underlying malignancy, and now he has a necrotizing bacterial infection that cavitated and is creating this gas, especially if it's an anaerobic process, this gas liquid type of cavitary lesion. But I agree. I think it's hard pressed not to send an extensive workup in this patient. I would first start off with an HIV. I think immune status is very important to delineate here. And I would love to know clarify if the leukocytosis of 22,000, if it was all neutrophils or if it was a combination of lymphocytes or other things too, like eosinophilia. I think that's the other thing I would have to add at this point in time. But I think immune status is very important here.
Great discussion. Just to clarify, so he was HIV negative. And then as far as a differential go, I don't believe that we fully obtained one, but we did agree with you all. We wanted to rule out some of these endemic kind of infections. So things we tested for commonly, strep pneumonia, histoplasma, the blastomyces, coccidioides. We also agree we looked for aspergillus. We tested that, cryptococcus, Legionella. We ordered all of those initial kind of infectious workup, and actually all of those tests were negative. So that led us to pursue additional testing with a respiratory culture, a sputum culture. At this particular facility, we did not have access to bronchoscopy to do BAL, so we did what we could with the sputum. And so that respiratory culture was actually positive for Pseudomonas. We had a quantiferin gold test that was negative. And then on that sputum culture, the acid fast smear showed 3 out of 3 Mycobacterium avium intracellular complex and then MTB complex negative. So kind of wild here. Do I give our official diagnosis? Is this my, no, yeah, you guys just
No, not yet.
Okay, you guys go. So the aspergillus was negative. Sorry, I'm looking at the chat too.
Okay. Aspergillus was negative, Mycobacterium avium was negative, and TB negative. Okay, so we have Pseudomonas.
Oh, the mycobacterium was 3 out of 3.
Ah, okay.
It's positive.
Okay, so the mycobacteria was positive. Repeat HIV was negative. Sorry, I'm trying to think and say at the same time. So yeah, it was actually, like, we have been seeing a few cases of mycobacterium being positive even in patient that it's not HIV. We saw here a few ones, and like patients like that are immunosuppressed can have a mycobacteria too. So that make me think if this could be the case because the HIV is negative. And yeah, and we already have Pseudomonas. What do you think? Yes. Sorry, I'm trying to think with all this information too.
I'm thinking that Pseudomonas could have been like a superimposed infection here, because thinking about tuberculous mycobacteria here and having the Mycobacterium avium positive, I would start this patient on this. I had my own mnemonic, the area regimen, which is azithromycin, rifampin, I think it's ethambutol and amikacin. I think that's the regimen for MAC. So I see Dr. Mark, attending Dr. Mark here in the chat. So maybe he can correct me if I'm wrong. That's what I would start, because having 3 out of 3 positive already, having a sputum culture positive, it has like high predictive value here. So yeah, that's everything I would have to say right now. Attending Dr. Jas, what do you think?
Yeah, no, this is a surprising twist. Even though we were talking about this, I feel like the sputum culture of Pseudomonas, how much emphasis do I need to put on that right now? There's 2 possibilities. One, it is a primary pathogen in structural lung diseases. It's a colonizer. It can be like either an infection or just could be a colonizer. We know that patients with bronchiectasis, this is something that is often seen, and you don't have to necessarily treat that. So is it just, but the thing is, the CT did not find any bronchiectasis, but still, it could still be a colonizer, or it probably led to this when we started having this progressive dyspnea, intermittent fevers, it was probably the driver behind that. So I would love to get my infectious disease consultants and pulmonary consultants to see if do we treat this Pseudomonas. But the bigger picture here is that the 3 plus acid fast mycobacterium, and TB is less likely. Like Mark mentioned in the chat, the cavitary lesion is atypical. What I think, especially with this weight loss, and the cough that he was having, I know Lady Windermere is more for the female population, but could he be having Mycobacterium avium complex that created this cavitary lesion, then got a secondary infection, or this just progressed further? He has a cavitary lesion, he has nodularity, and then he has bilateral hilar adenopathy. I think in this case, I also would not want to miss nocardia, and he may be HIV negative. I would still send the RNA just to make sure it's not an acute infection. And I also would check his IgA, IgG, and IgM to make sure he doesn't have a CVID of like why, if this is Mycobacterium avium complex. It could also be Kansas, but I think this is an NTB that was brewing in the background, and either it just took an acute process and just got worse to the point where he came into the hospital, or the cavitary lesion itself, especially with the air fluid cavitary lesion, that cavitary lesion got infected itself, which officially brought him into the clinic. So I think this is what I'm thinking of, and I agree, malignancy is still probably in that situation, but I think right now, I think what he had this probably longstanding lung history. We don't know because he's not a regular that comes into the clinic and hospital. So that probably led to the NTB exposure, put him at vulnerability, and then the acute decline from this pneumonia. But I mean, I would love to know. I think that the hallmark then for me to say this is just NTM, sorry, is the air fluid level, the gas and the fluid in the cavitary lesion, which makes me think that the Pseudomonas probably was an active driver here. But I would love to learn from this case. Thank you all for bringing this case, and Yaz and Deborah, you guys were amazing. But before we give it to the case presenters, anything that you guys wanted to add?
No, I think what you said about the cancer is really good. Like the patient has the smoking history and the family history, so maybe there's something else happening. And yeah, I'm curious to know the final diagnosis.
Yeah, okay. Well, for us, our final diagnosis is bilateral cavitating pneumonia in the setting of MAC and Pseudomonas infection. Kind of our underlying thought is that his underlying emphysema and then external exposures really precluded him to getting this chronic MAC. And then it really just sat there and festered and festered, and then he developed the Pseudomonas on top of it. And by the time he came into the hospital, unfortunately, it progressed too far. That's something we see a lot in North Carolina is folks who just let things kind of fester and come into healthcare at a really, really long, far into their course. And so this is unfortunately very typical, not the MAC, but this type of patient coming in late in a course for this type of infection, something we see a lot. So he was a really special patient, and a lot of members in our team took care of him, and we learned a lot from him. So thank you all so much for letting us kind of bring him today and letting us learn from him. But would be curious on anyone's thoughts about all this.
To your point, Yaz, I just wanted to let you know that he was treated with azithromycin, rifampicin, ethambutol, and amikacin with our ID consult team.
Yay! I'm so happy. Like honestly, I really like ID, so this case is like so good for me. I know that I say I'm not going to anchor an ID, and yes, every time I say maybe this is not ID, it ends up being. So it's really nice. Thank you so much for bringing this case.
Yeah, I don't have much to add either. I know Nicole and I both took care of this patient, her longer than I did, but definitely a very special guy, a lot to learn from, and great case.
Amazing. Thank you so much for bringing. Was awesome to learn with this case. Thank you, Jess, for guiding the discussion.
Like I said, you guys were running the show. I was just there for structure overall, but it was great. I just want to comment on the three of you's empathy. I think it's the first time I've seen case presenters say that we didn't just learn from the case, like we learned from him, and it was a pleasure to hear him. So I noticed that subtle language. So thank you for showing your empathy side on VMR.
Of course, he was very grateful for all the care we could provide him and his partner as well. They were just two great human beings in a very unfortunate situation.
Mm-hmm. They truly impacted all of the attendings and our residents, and they're still talking about this patient to this day, and so very special. So thanks for giving us this forum to honor them that way.
Yeah, thank you very much for bringing this case to us. And I think it's a great way to start to speak about the residency program, because I feel that the residents are, the way that they speak about their patients is also a reflect of their relationship as a residency program. So no better start for that. Would you like to say, just like to give an overview about the residency program, maybe about the schedule or the things that you most like about the program, and we can start. And if you all have any questions, you can put the questions in the chat and I'll read them out loud.
Yeah. Lily, do you want to start or you want me to go for it?
Oh, either way, we love our program, so
Yeah.
You can go ahead, Zach, and then I'll hop in.
All right, yeah, sure. So I think, all of us are fourth-year chief residents have absolutely loved our time in this program. And I think I can speak for all of us in saying it's a huge honor that we got to be chief residents and represent the program. I think specifically mentioning the schedule, I think that's one of the best parts about the program. I would kind of caution in general, like the objective things are super important, but the subjective interactions you have with people, I think, are the most important thing about choosing a residency program. But for us, our interns have a 3+1 schedule. So they have 3 weeks of inpatient and 1 week of outpatient every month, and they'll rotate through that. And I think that ends up being a perfect amount of time where you get to know your team, the flow of the work. But by the time you're getting exhausted, you're able to kind of rotate off and have a great week. I think where it really shines, though, is our upper level schedule is actually 4+4. So we have a month of inpatient followed by a month of outpatient or consults. And so it's really fantastic. I know we all talk about golden weekends, but having 4 in a row, I mean, is really fantastic. And then for me individually, what I love about the program is just the culture that we have here. It's so positive, and Lily and Nicole and I have all been really close friends all the way dating back to our intern year. And we're all staying around for fellowship just because of how awesome it is. So happy to have anybody else chime in for me as well.
I'll hop in if that's okay, Nicole. So what I love about the program is that it's very, it's a large program, and of course the schedule things that Zach said are amazing. But within that large program, they're so people focused and people oriented. And coming to Wake Forest, I had a totally different vision of what I thought my future was going to be like. But my chief residents, my upper levels, the faculty really saw what I was good at as a doctor, as I was learning skills, and they honed in on me and pushed me towards a career path that I never would have imagined. And I think they do that for most all of our residents. We get to know each other on a very personal level and really focus on what's the right career path, what's the right personal development. And I think that extra layer of interest and desire to help you become your kind of best self, both as a physician and as a person, is just so unique. And I have felt that support from day one until now as a chief resident, and then I'll be staying as a pulmonary critical care fellow. And I'll be consulting Zach and Nicole quite a bit as our future cardiology fellows. But I think that extra personal touch is just something that you can't find everywhere, and it makes us really special and really unique.
Yeah, I agree with everything that Zach and Lily have shared. Something else that's really great about our program is the diversity of tracks based on your interest. So we have so many different tracks that you can join, whether that be a hospitalist tract, primary care. We have POCUS champions. So just a plug for Wake Forest. We have an excellent POCUS curriculum that Lily is actively head of as the chief of that department, and so I think we're really skilled in our ultrasound exam there. We also have medical education pathway if you're really interested in doing that in your future and working with medical students. They're frequently on probably almost all of our rotations, so we're really close with medical students at Wake Forest. We also have Tinsley Harrison Research Scholars, so if you're really dedicated towards research, you have a pathway for that. So we have a lot of different flexibility, and you can be in all the pathways you want or no pathways. So I think our program is really dedicated to the individual, which is nice, and they will make something out of whatever you have an idea of. And I think the close access we have to attendings and fellows also broadens the experience for research opportunities or just getting to understand what your career could look like if you're interested. And there's constantly flip-flopping, and you don't need to know what you need to do, what you want to be when you walk in. And I think our program is very open to that. And everybody has open door policies. We have the phone numbers of so many of our attendings, go to their homes for dinners. So I think overall, like Zach said, the people that we have here, I don't know how they find them, but they're true gems.
Fantastic. Thank you very much for sharing that with us. And there are a few questions in the chat. Simi asked, how is it living in Winston-Salem? What do you guys do for fun?
Oh, we have quite a bit of fun in North Carolina. So we love Winston-Salem, number one, because it's so easy and comfortable. The city just is like an open arms, welcoming new folks coming in. So it's very easy to get plugged into different activities. But there's a great food, restaurant, and kind of brewery culture in the downtown area that we all enjoy. And then I think you guys can all tell the three of us like to work out and be pretty active. So there is just like unlimited opportunities for structured fitness classes or kind of free-for-all outdoor activities. But really just a cultural boon too. Zach, I'll let you talk about kind of the arts, because Zach's wife promotes one of our really awesome things here in town. I'll let him talk about that.
Yeah, absolutely. So my wife works at UNC School of the Arts, which is one of the art conservatory universities in the area. And so we have a bunch of local plays, musicals, ballets. My wife has taken me to the Nutcracker every year that we've been here. I didn't realize the first time it was a ballet and not a play. So when nobody was talking, I was really surprised. But overall, really great. I think the underlying thing about the city that I really enjoy, and sort of what Lily had mentioned, is that it's sort of a small but growing city. And so it's small enough that you can have places that are like your go-to spots that you're like, let's go here this weekend and let's do this, but it's growing at the same time. So every few weeks or every couple months, there's some place new that you can check out, which I think really makes the city exciting and fresh.
And also, we have two airports pretty close by. So we're close to Greensboro that has an airport. And then Charlotte is, like I said, only an hour and 15 minutes away. So it's really easy on the weekend to go to Charlotte if you wanted, more sporting events. Like I go a lot to the Panthers game there. They have minor league baseball. They have the soccer, they have basketball, they have concerts. So that's a really easy drive to go to. But a lot of outside like parks and hiking are not far from Wake Forest where we live too. Just gonna put a plug in for Tanglewood. It's an amazing park that we have, and you can ride horses there. So plug for that. And yeah, lots of different food scenes.
Awesome. And there's another question here. So Nicole kind of just mentioned the different tracks that there are in the program. Just on the specific questions, the residents are able to apply for these different tracks in the second year or in the first year. How does that work?
So at the end of your intern year, you can start applying for these tracks because it's really hard to transition from a medical student to an intern. So we want you to just focus on learning how to be an intern, getting your schedule together, and not having any more stress. So like the first 6 months, focus on that. And then as you get used to, being an intern, then we start opening up the applications. So that's what our interns are doing right now is applying to different tracks. And also you can apply in second year if you decide you find an interest in something else later, then that you're always welcome to apply. There's no restrictions on what year you're in.
Awesome. And another question is, how does research work in the program? Do you guys have kind of a mentor that you can reach out to collaborate on research, or is there any support from the program leadership about research?
Yeah, so I'm the chief who helps do our research here and kind of run that process. I think it's pretty robust. I think we have a good kind of blend of kind of set mentors that we have available to you that can help be kind of footprints within departments. But at the same time, there's a lot of organic mentorship that occurs, and we have a list of actually ongoing projects through a red cap that we end up sharing with our residents so people can pick up on projects. And this year, we're still kind of working on the development. Basically, there's a lot of upper level residents that have projects they've been working on that have been ongoing for a year or two, and so they're trying to get other residents involved in those. And so we now have a database that kind of shares projects within the residency, and so you have mentorship in faculty, but also mentorship among your peers. And so I think it's a really great opportunity to build your research portfolio and sort of an area of expertise that you can talk about when you move on to the next step of your career. In terms of sort of official events, we have a couple of things that we've done this year that I've really enjoyed is we have a research meet and greet. So we basically have faculty from every specialty, and we do like a speed dating where residents can kind of come in, rotate around the tables, kind of develop mentorship, set up later meetings, which is really awesome. And then we're actually having our IM research symposium coming up here in May, where anyone affiliated with internal medicine, whether that's medical students all the way up to early faculty, can submit. And we have our own conference actually at our residency program. And so every year we have 75 to 100 abstracts accepted. And so it's a really fantastic way. And research is certainly encouraged. That being said, if it's not something you're interested in your career, it's also not forced upon you. So there's really the gambit of what you'd like to do. And so I think there's a lot of opportunities no matter what.
I see there's a plug in the chat with about Dr. Lippert. So I guess we'll say he's our favorite mentor, wink, wink, as he's probably going to text us during this now.
We had the pleasure to have Dr. Lippert yesterday, and I have to say, I am not even in the program, and he is my favorite mentor. Deborah, yes, do you have any questions for the chiefs?
I think normally what I ask it's about research and focus, but I could ask like if you guys have a morning report too.
Yeah, so we actually do noon report, which we love. And so it's a everyday conference that is accompanied with lunch. And throughout the week, we have a very kind of set schedule. Mondays are our resident grand rounds. So each of our third year residents get to present on a topic of their choosing, which has just really been so fun to get to learn from different opportunities. Those alternate with our POCUS pathway curriculum. So we have the pathway. You can be in it, have your individual training, but each of the POCUS champions creates presentations and they give those to our entire residency program. So whether you're in the pathway or not, you do get to have those pretty in-depth and specific lectures, which I think are fabulous. Next are Tuesdays, which is our core conference day. Our faculty come, and we have a range of faculty. It's really exciting, from internal medicine and then our external partners as well. So dermatology, the orthopedics team, podiatry, all of those folks that we end up working with quite a bit come in and give lectures too. And then our Wednesdays and Fridays are our case conferences in a very similar format to what we do here, where we work through cases. In a variety with, different caveats. And then Thursdays are our internal medicine grand round. So as a department, we're able to go and support all of our faculty and meet all of those faculty members and see their presentations. So we love our noon conference series. It's been so fun to get to be on the side of coordinating it this year. All of us get to take a big part in it as chief residents. So that's been really fun.
Fantastic. Yes. Do you have a question for us so we can?
I wanted to ask about the morning reports, but Deborah got ahead of me. So yeah, I was actually very interested in like focus. Like, do you have like a rotation, like track or about it?
I'll go ahead and keep talking. I'm our POCUS chief. So the POCUS pathway is something that Nicole and Zach and I all completed as residents. Like Nicole was saying, you apply at the end of your intern year, and this is a really focused, specialized group for POCUS training. You do one-on-one sessions with some pretty amazing technology with our POCUS APD, Dr. Kelly. We have this amazing equipment called Vimidex or Vimedex that lets you have a dummy and an ultrasound and work through fake cases. On top of that, we do SP training and procedure training that are kind of one-on-one specialties, and then gel rounds on the wards with all of our additional faculty. Associated with that pathway are some different modules and training through the ACP, which are currently, our only way to standardize training is through those ACP modules. So you have time to work on those. And then we get to present these lectures to the rest of the program, which is really neat. Our POCUS champions dive very deep into very niche POCUS topics and allow for, they get to learn and then they get to teach it to the opportunity. So we like to say the program enhances your POCUS skills, but also allows you the ability to learn how to teach how to do POCUS. And so it's a kind of a double-edged sword in a good way, is what we think of it, but it's been really fun.
And to wrap it up, I just would like to thank you again for being here with us. And we just like finished one match season, but there's another one right around the corner. That one finishes and another starts right behind it. And I just would like to ask you to give one tip for the people that are going to apply next season. What do you think made you stood out to the program, and what do you think would be helpful for the next applicants to know in order to apply for Wake Forest? It can be just like a short phrase, and we can wrap it up.
I think something that really stands out in general is longitudinal interest in an area. So instead of putting things that are like one-day experiences, if you have less things, but they're more longitudinal and you show a real interest and expertise in that area, I've always found that really interesting, because the goal in an interview is for you to be able to talk about something that interests you and you have a passion about. And so I would just say longitudinal experience, even if that means a total number of less experience, I think is really helpful.
I also think something as chiefs, we're really active in the recruitment process, and we also participate in the interviews. I think personal statements, honestly, just talk about you, because we just want to know about you, what kind of person you are, and because we're looking forward to working with you for the next 3 years. So if you can focus on talking about you, I think that's a great thing too.
I was thinking the same thing as Nicole. Our brains are in the same spot. But when you're applying, I would think about your passions and what drives you, and be ready to explain that in your interviews and kind of tie that to each of your events that you've written about on your personal statement. And even if it's like, oh, I did this random thing, say, well, I was exploring this part of my medical journey and I did that and I learned this from it. So thinking about those connections and how they kind of route to your story, and unifying that even in an interview, even if maybe on paper it doesn't quite connect, is really important and powerful, because you did all this work and it does matter and it did shape you. And so you've just got to make that story for the people you're meeting on the interview trail.
And we love the hobby section because I feel like that's probably what we ask most about because that's how you relate to people. Like, oh, I didn't know you did this. I do this too. So don't slack on the hobby
I was
section.
going to plug the exact same thing. The hobbies are crucial and don't underestimate them.
Yeah, that was our favorite part was reading the hobby section because we
Connections
want to know
are
about you. That's the most important thing.
Awesome. Thank you so very much for being with us today. I hope you guys enjoyed participating in Sipsovers, and thank you very much for the ones that joined us today for the discussion. Thank you, Deb and Yaz and Jazz, and thank you, Julia and Lyra, for helping the session to happen. And I see you guys tomorrow in another VMR. Bye.
Bye. Thank you all.